Thank you to the previous speakers, and for that anecdote, I really don't know how to follow it. I sat there thinking about it and I totally forgot it was my turn. So thank you for that. And also grateful to the APSF Planning Committee and to May for making the time today to talk about these important topics. I think it really is part and parcel to what we know APSF to be all about in terms of revolutionizing and really pushing the boundaries of patient safety. So it's an honor to be here and to spend time thinking about these questions with you. My name is Grace Lim, and I am going to be talking about patient-centered care, quality, and setting up a research agenda to address issues. But May also instructed me that I was supposed to talk in a way that will engender conversation, which I'm excited about, and I certainly have really enjoyed about this meeting format so far. So I'm going to spend part of the time telling you a bit about this thing called the Elevate Project, where we attempted to tackle some of these questions. But I'm also hopefully going to spend some time posing some questions back to you. And I'm really hoping that by the end of this conference, we will come away with not only a shared agenda here, but maybe some tractable things we can really do to, once again, push the envelope and push the agenda further and to really make some reform here. So I do have some disclosures. The relevant ones to this talk are that the work that I'll be presenting to you was funded by PCORI, and that I'm working together with a large language model innovation company at CMU that's going to be developing some communication tools to be used at the bedside along the lines of the things that we're talking about today. We are here because maternal mortality and morbidity in the US remain unacceptably high. I'm hoping we're at a point in the conference where none of us will argue this point, and I'm not going to be sharing any more data about this because I think you've all seen as much of the data that I know about. But I also am hoping that at this point in the conference, we are coming to a shared realization that maternal safety is not only about physical survival, but it's also about dignity, respect, autonomy, mental health, and long-term outcomes. This is the next frontier, I think, of anesthesia practice and how we define patient safety, and I'm so glad to be thinking about these things together with you today. For a long time, for several years now, we have recognized that women deserve more than just to know they're going to survive childbirth. Since 2018, the WHO has made statements, has made recommendations really focused on elevating the need for delivering respectful maternity care. And so these are not new issues, although these might be new ways that we are framing them and hopefully disseminating them. And so as anesthesia professionals, I think we really are this bridge between recognizing the need for physical safety, not only for mother and child, which we've talked a lot about today, but also the mental safety that's required of achieving those really good outcomes that I think we are all striving for. And so far in this panel, this segment, we've talked about trauma-informed care, substance use disorder, and management. And I think that is part of a systemic solution in terms of that's how we show up at the bedside. And so if that is how we show up at the bedside, then patient-centered care and developing research and pursuing those agenda are how we show up at the system level. And so I do think that these are both equally important and deserve equal amounts of attention, effort, and ATP. So here we are I'm supposed to talk to you about this, and what I'm going to do to try to accomplish this goal is to tell you how we attempted to tackle these things in terms of quality research agenda through the Elevate Project, which stands for Advancing Patient-Centered Care Anesthesia Choices During Cesarean Delivery. This was a labor of love between several professional organizations and experts. We were lucky to bring together not only anesthesia professionals, but also payers, quality experts. We had representation from our state maternal quality collaboratives, but also had representation from those in insurance payers and those who are informing Joint Commission and CMS in terms of how we report and measure quality bundles. So the reason why we got all these people together is because, once again, we work in a system of care. So it not only is about how do we show up at the bedside and what do we do for that patient in front of us, which is extremely very important, but how do you systematize that across every single patient that has the same condition, whether or not it is you at the bedside or your colleague that you have been working with to improve these pieces of care. And so we got this group together to give voice to the issue, and also to put together an agenda that was comprehensive and took a multifactorial, a multifaceted lens on just how to systematize these potential solutions. And so the problem we were trying to tackle was pain during cesarean delivery. We also learned by opening up this can of worms, there was a lot of other things that go along with that. Quality of labor analgesia management, quality of conversations, prenatal anesthesia consultation. And the obstetricians who were part of our group also raised the fact that we are probably, as a system, not great about talking about cesarean deliveries in general. So patients are showing up for care needing this thing at the 11th hour, spending most of their 40-week gestational period trying to avoid this thing that we are now confronting to have to deliver to them within 5 minutes. But that was the thing that brought us together, was what we were all, trying to solve a problem regarding pain during cesarean delivery. We also recognize this lack of ability to engage true shared decision-making during these situations, that the lack of trust in some of our demographics is also factorial in these issues. And then we also recognize that pain is only one outcome, and potentially for a long time we've really been focusing on this number, but patients have a different perspective on what's important. And although although this number may be important and is measurable, replicable, scalable for us, they also prioritize other things, like how they were spoken to or whether they felt they were listened to, which are not as easily measurable in those situations. So our focus was to try to empower patients through informed anesthesia choices for cesarean deliveries, and we were attempting to bridge these critical gaps in experience, safety, and equitable care access. So these were our goals. We also had a vision where, a world where all birthing people are able to receive equitable and personalized and evidence-based care. Some of you are in this picture, and I'm thankful for all of your participation. You might notice, and May, thank you very much as well for being part of this group. Our methodology was primarily a mixed method, meaning this group convened several months before a summit that we held in person, and had several conversations with us, not only one-on-one interviews, but also completed sort of targeted surveys. We used both of these things together and in a cycle, so that the interviews informed the questions then informed the data-informed additional interviews. Essentially, we were iterating on what the key issues were, what the barriers were, what the facilitators were for a potential solution, and whether we could even arrive at a consensus on what an agenda should be. And so we learned a lot in these conversations, and thematically found that we had shared ideas about the fact that this was an issue, but also had disparate ideas about what patients thought were solutions versus what payers thought were important and what quality experts thought were tractable. And so through the in-person summit that we had in January of this year, those were really the key issues, the unresolved issues that we were not able to get through this initial mixed methods approach. The reason for us getting together was to see if we were able to resolve some of those items. And all of these things can be found at elevateproject.org. At the bottom, you can abstract the report that has everything that we did together on there, the results. And so I mentioned some of the stakeholder engagement here. We had a diverse sampling here across multiple stakeholders, at least 40 organizations, trying to get a representative sample not only of academic organizations, but also community practices, both urban centers and also rural centers. And I mentioned that we were interested in including community perspectives as well. So we had patient advocates and doulas as part of our teams as well. And so these are the highlights. We identified core research priorities related to this topic. And the power of this is that this was not only the OB anesthesia experts deciding that we were going to compare cocktail A versus cocktail B. This was OB anesthesia experts together with all these other stakeholders saying, okay, that sure is interesting, but maybe we should be thinking more broadly in terms of how the care is also delivered and measuring outcomes that are more distal or long-term, which is what's important to patients, and then measurable outcomes on mental health, which has been lacking in some of our pain research so far. For patient-centered outcomes, we arrived at several understandings. One is that certainly pain management is important. Patients did say that, but also they truly value a sense of control, autonomy, and feeling heard. They want to have limited long-term trauma. They're clearly trying to balance this with neonatal success goals. They also think that the HCAHPS things that we do here with patient satisfaction is not necessarily helpful in these ends, and that was an interesting nugget of information that we learned. And just sort of trying to navigate these conversations while balancing their different priorities is something that they found valuable also. A key finding we found here, and we've, in some subsequent research that our group has done, we've replicated these findings at least a couple of times now, is that patients and stakeholders aren't necessarily, patients and providers, are not necessarily on the same page about these goals. Now, that might be initially surprising at face value, but when you think about it, it may not be as surprising. When you're confronted with a cesarean delivery, which many of us might find as routine, we do many of them every day, maybe in our career we've done several thousands of them already, we have certain high item things on our agenda that need to be done. Oxygen if necessary for the baby, timely administration of the anesthetic, several other things. However, for the patient, that is their first experience with it. They may not have the same goals in terms of receiving medication for what might be perceived as discomfort if they had not been, talked to about that at one point. So what we learned in terms of our mixed methods analyses over here is that there are quantifiable ways in which patients and providers are actually prioritizing very different things in that moment of care. And that should be seen not necessarily as a major problem for us, but it should be seen as an opportunity for us to partner better with the patient, recognizing that, okay, in my mind, as a provider for this patient who has to do safe and timely care, I know I need to do X, Y, and Z, but how can I also meet their needs where they kind of just need somebody sitting there talking to them and telling them about everything that's going on? Meaning I don't have to be the hero in this conversation or in this equation all the time. Perhaps the labor and delivery nurse could be helpful right at the bedside, right next to me while I'm applying monitors and talking to the patient, especially since they have a rapport with the patient that may be deeper than the one that I just formed with them. Or similarly, and we'll talk about this in a little bit, but the role of doulas. Doulas are non-medical but patient advocate types of people who stay at the bedside with patients who are in labor. Many of you who do labor and delivery encounter them all the time. There have been many conversations that we learned through Elevate about the potential role of doulas in these situations. They're not typically thought of as OR team members or even as care team members, but is there an opportunity for us to get creative about the people in the circle of trust with the patient so that we can all move to the same goal of a good outcome from a mental health perspective? And then we also discovered barriers. There's some systemic barriers. We heard a lot about how, wouldn't it be great if we could all do prenatal anesthesia consultations? Immediately, some barriers that we heard about were in the private practice where, you have one anesthesia person doing all the things, and there just is not a feasible way to get on the phone with every single pregnant person who may be coming that day. And so we may have an opportunity here to get creative about the way we do prenatal anticipatory care. Once again, do we have to be the heroes of this equation? Do we need to bill for that? Or is there a different way that we can integrate this type of education as a team with the patient in a way that meets their needs while also confronting the realities of the strained workforce that we all have on the anesthesia side of things? And we also talked a lot about facilitators, in terms of things that we can leverage now or in the future to address some of these considerations. We definitely heard a lot about the need for building trust and building these relationships. So that increased presence of support people was something we talked a lot about. We discussed risk assessment tools. Are there better ways that we can help the providers at the bedside to recognize a situation that needs intervening? evidence-based driven medications for shared decision-making, and then care that supports patient autonomy and controls are other things that we found as facilitators. So these were our key findings. All of the stakeholders together can agree that the patient-centered things that are important for patient-centered outcomes that are important include a sense of control, managed pain, emotional and mental or psychological well-being, and neonatal success. We also identified barriers, facilitators, and multi-pronged solutions. And so when I was thinking about this in the context of this meeting, I got very excited because APSF has this rich history of transformative care that radically improved anesthesia, so that and you're all familiar with statistics. IOM has held us up as a poster child for patient safety. We went from the #1 killer of people having surgery to the least likely thing. And how did we do that? A number of ways, one of which included better tools, better monitoring, the pulse ox. I just had a great conversation at lunch with Alex and Tim, who told me about their experiences throughout their professional life of going from not having any of this, looking for BRB, bright red blood in the field as an indicator of oxygenation, to a revolutionary practice of adding this very simple thing to the patient's hand and identifying oxygenation before you could see it. Unfortunately or fortunately, this device is now in the Wood Library Museum. And there are some people in the audience who remember even using this Nellcor device. But it really got me thinking about what is our pulse ox to this solution? This past hour here or so, we've been talking a lot about some pretty abstract things that are not measurable by a pulse ox. And yet, in order to make that needle really move, perhaps we need something as simple and scalable as a pulse ox to tell us when something's going on and to give us some directionable action. And so I think that's a key question that I'm going to pose to you, and I'm going to be really eager to hear your thoughts about it in terms of what are our scalable solutions. I also think about it in the context of this major challenge here. We have this issue of scalable solutions, this challenge of, how do we get a best practice out? And I was glad to hear about some of the implementation science ideas that are, through the experts that we heard this morning. But here's the reality. There are more than 5,000 hospitals in the U.S., of which, 2,300 or so are doing deliveries. And that number is shrinking, as I'm sure some of you know. And so those are the numbers, and yet these are the numbers of, let's say, accredited USA medical schools, which is, there's only 120. So that's kind of the way I tried to get an idea of how, university-affiliated training institutions. I'm sure there's a better way to assess this, but there's a fraction of those hospitals, in other words, that are in the environments that many of you and I, we are coming from, a teaching environment with that has the ability to influence what the next generation does with these challenging situations, for example. And, similarly, a fraction of those that are accredited anesthesiology residencies. I was not able to find similar numbers for the SRNA programs, but I'm sure some of you are familiar with these numbers, and I would wager to guess that they're in the similar hundreds or so. So a fraction of the number of hospitals and training programs, in other words, are representing the opportunity for influencing training and education on what happens in the 5,000 hospitals that, are specifically 2,300 of the maternity hospitals that are delivering maternity care. So that's a pretty big gap, I think. And quantifying it in those terms, I think, is also hopefully helpful to this audience in terms of thinking about that scalability question. What is the bridge? How do we bridge this gap between the training and what's happening everywhere, which is a pretty big gap. So we heard some of those ideas with Dr. Main earlier in terms of using some of the hammers and levers that we have with accrediting organizations. Is that a direction we need to go? What's our pulse ox here, basically, or the next generation of a pulse ox? And so I'm going to take a page out of our anesthesiology history books and think about this together with you. How did anesthesia become safer? What does the IOM, the Institute of Medicine, say when they were, holding us up as poster children? They brought up, consistently we hear about three things. One, increased and improved safety standards. That really comes down to training and education. Two was advanced monitoring, EKG, the pulse ox, capnography. These are what I'm going to bucket as tools, because although I can't immediately imagine something in those categories that might help us with these situations, although perhaps it's just a lack of imagination on my part, that just kind of buckets into this idea of tools. And then finally, improved drugs and delivery systems. So moving from very impractical or the drop methods of highly dangerous volatile agents to better and more targeted therapeutics that going through the intravenous route. These were really important innovations and new approaches that revolutionized the way anesthesia care was delivered. And all of these things together made anesthesia safer. And so once again, I'm going to pose to you, what are these implementable, scalable solutions? How do we implement them? How do we test them? What are they? And so for example, when it comes to training and education, do we need to revise, revisit, re-examine our boarding process, the milestones, for example? How do we assess these types of competencies? How do we teach them? Is there a standardized curricula that needs to be delivered at each of those 180 institutions or sites? The current workforce would need to be brought up to speed as well. So these are things to think about. One way that we approach this is through the delivery or the teaching of empathy skills with a mnemonic called NURSE, which stands for Name, Understand, Respect, Support, and Explore. We have a little letter in anesthesiology that was published not too long ago showing that this did make a big difference in not only the patient's feelings or the measurable instances of trauma or acute stress disorder, but also the residents felt more confident in their ability to deliver empathetic care in high-stakes situations. So perhaps this is one of potentially many solutions of scalable, curricular ways that we can teach this, not only to our current, next generation, but also to people who are currently delivering this type of care. This pulse ox idea, do we have standard monitoring schemes? I don't want to steer, break any surprises here, but I'm hoping we'll hear from Dr. Heather Nixon a little bit later today, who will talk a little bit about some innovations that she's done in terms of assessing intraoperatively, how patients are doing in ways that are actionable. Or are there some innovative devices that can help us, raise awareness on what is happening here and what we can act upon? And then finally, once again, in the past, we moved from halothane and other types of volatile agents to more targeted intravenous approaches or better inhaled anesthetics as well. Do we need to think about some new approaches to the way that we deliver care? Are there new or different pharmacologic approaches? Do we have to should we reconceptualize the role of support people, not only at the bedside in the labor suite, but also maybe in the operating room? These may not be immediately obvious questions that can be answered right now at this moment, but perhaps are questions that are worth contending with or wrestling with. And so, taken together, I think that if we take a page from our history books and think together about what we might be able to do that pushes the envelope, that really does tackle these problems in a meaningful way, then perhaps we can move the needle on some of these issues that we've been talking about. And so that's all I have for you. Thank you for your attention and your time. And once again, these are just some ways that you can get to the report and other key findings from our group. So thank you.